Welcome to Raaonline. Today we are going to see about how will you use the base excess to assess the acid-base disorder. So, to approach the acid-base disorder, there is three approaches are there. One is a physiological approach, we call it as a Boston. Second is a base excess approach. The third one is a Stewart approach. In this approach, we are going to see about what is the background, why the patients use the base excess to assess the acid-base disorder. What are the alternative to that? Some people are used to standard bicarbonate, some people are used to buffer base, and finally they started using the base excess. So, first we see that what is the historical perspective. So, first you see here there is a 1952, there is a poliomyelitis epidemics. Lot of patients are died because of the poliomyelitis. At that point of time, there is a 1952, there is only one acid-base laboratory test was available, which is they used to measure a total carbon dioxide concentration in the blood, which is actually a measurable bicarbonate, which is called as a total carbon dioxide concentration in the blood. They found in the poliomyelitis patient, the total bicarbonate level was very high. They call it as a unknown origin of metabolic alkalosis. Okay. So, they call it as an unclear origin of metabolic alkalosis. So, there is a lot of patients are died. They held as a emergency meeting in those epidemic region. One of the anesthetists is called as a Ibsen. He realized, so this increase in the bicarbonate, it is not because of the metabolic alkalosis, it is because of the increased PCO2. The poliomyelitis patient had respiratory muscle weakness and bulbar paralysis. Because of this weakness, these patients had retained carbon dioxide. Because of that increased retain of carbon dioxide, which is increased the bicarbonate. So, it is not a metabolic alkalosis, it is a respiratory acidosis. So, he brought lot of medical and dental students to provide a ventilation to these patients. So, a lot of patients are saved, around 100 patients are saved. So, subsequently he said that, so it is not metabolic alkalosis, respiratory acidosis, and also he said there is bicarbonate will increase, not only it is a metabolic acid-base disorder, it also increase in the respiratory acidosis, bicarbonate level will change in the respiratory acidosis and alkalosis also. Okay. So, it is very important before going to use the base excess approach, it is called something called Copenhagen approach. So, in this approach, there is two approaches are very common. One is the physiological approach, we call it as a Boston approach. The second approach is called alternative base excess approach, it is a Copenhagen approach. It is US based, is the Dutch group. The Copenhagen group used to criticize the physiological approach. This is the Boston group used to criticize this base excess approach. Something is called, this criticism is something is called the Great Transatlantic Acid-Base Debate. Okay. So, what is that? Why they used to criticize with each other? Okay. First, based on the physiological approach, we will discuss in the previous class in the physiological approach to acid-base disorder. There is two things. So, acid-base disorder can occur in the two ways. One is the respiratory origin, maybe the respiratory alkalosis or respiratory acidosis, or metabolic origin based by increase in acid level in the body or decrease in acid level in the body. So, we will identify the acid-base disorder from the respiratory origin by the primary change in the PCO2. For example, the PCO2 is increased or decreased, this metabolic acid-base disorder is a respiratory origin. Okay. So, on the other hand, if it is change in the fixed acids, acid is added to the body, it is the acid-base disorder because of the metabolic acidosis. If the acid is removed from the body, it is a metabolic alkalosis, this is acid-base disorder because of the metabolic origin. So, we can identify the acid-base disorder based on the PCO2 and the as change in the acid level. Okay, one. Second thing, the magnitude of acid-base disorder also will give identified by the change in the magnitude of change in the PCO2 and magnitude of change in the fixed acid. Okay. If something is correct, example, whereas this PCO2 is increased, it is called a respiratory acidosis. Okay. So, we identify the pH is low with PCO2 is high, we call it as it is an acid-base disorder, is respiratory origin. Okay. Second thing, if the one patient have the PCO2 55, other patient have the PCO2 of 80. Okay. Which means that this 80, the PCO2 retention up to 80, this patient have a higher respiratory acidosis. The magnitude of change in the PCO2 will give idea about magnitude of acid-base disorder. It is for the respiratory disorder. What about the metabolic disorders are quantified? Its amount of excess acids are added or removed from the blood will give idea about the magnitude of metabolic acid base disorder. Okay. So, it looks very simple. Okay. Can you measure the excess of fixed acid in the blood? So, no. Okay. We cannot measure the excess of fixed in the blood. Okay. What is fixed acid? Fixed acid means that is a non-volatile acids are called fixed acid. If example the bicarbonate, carbonic acid, it is produced from the CO2 and the water, it is a volatile acid. It produce carbonic acid will produce the water and the CO2. The CO2 will be exhaled by the lung. So, it is a volatile acid. If it is sulfuric acid, you cannot, ventilation cannot remove that acid called fixed acid. Okay. So, we cannot measure the fixed acid. So, we have to look for some other alternatively, we can indirectly measure the metabolic disorder by looking at bicarbonate level. Okay. If example, if I added some fixed acid, example HCl, hydrochloric acid or sulfuric acid to the patient's body, patient's blood. Okay. So, each one molecule of fixed acid will, if example, I am producing a sulfuric acid. Okay. This reaction will produce H plus and sulfate. Okay. This H plus is a acid. Okay. This will react with the some of the bicarbonate. Okay. So, one molecule of H plus will neutralize the one molecule of bicarbonate. Okay. So, every molecule increase in the H plus will decrease the bicarbonate. So, the one molecule, so bicarbonate will decrease one molecule of every molecule of fixed acid present. So, total amount of fixed acid added to the blood will equal to the total amount of bicarbonate concentration decreased in the blood. Okay. For example, I added the 10 molecules of HCl. So, before adding my bicarbonate was 24. What will be the 24 after adding the bichloride? It will be 14. Okay. So, from the bicarbonate level, I can measure how much acid is added to the blood or removed from the blood. So, the bicarbonate level will give idea about the metabolic disorder. So, we discussed about the historical perspective, that is during what happened during the poliomyelitis epidemic. Okay. What happened? Initially, they measured a bicarbonate. They thought in a poliomyelitis patient, they thought the bicarbonate levels are very high in those patients. They thought all this bicarbonate, this reason for the patient deterioration is because of the metabolic alkalosis. But later the Ibsen found this increase in the bicarbonate not because of the metabolic alkalosis, it is because of the respiratory acidosis. Okay. So, the bicarbonate, through the bicarbonate, we can measure the metabolic disorders, but it is not ideal one. Why it is not an ideal one? So, every time if I increase the PCO2, it also increases over bicarbonate. It is not only dependent on the metabolic component, it is also dependent on my PCO2 level. If example, this reaction is our Henderson-Hasselbalch equation. This is a bicarbonate buffer system. What happens? If example, my patient, I have the opioids, excessive opioid use, the patient ventilation will go down, my PCO2, my carbon dioxide level increase. What my body will do? This carbon dioxide level will react with the water, it produces the acid and the bicarbonate level. Okay. Here there is no metabolic problem here, there is no AKA, there is no DKA, but the bicarbonate level is increasing. Okay. So, the bicarbonate level is not only depends upon the metabolic disturbances, it also depends upon the respiratory component. Respiratory disorders also will increase over bicarbonate. So, this is the Copenhagen or this base excess group, that is a Dutch group, criticized the physiological approach. They said the bicarbonate, it's not only depends upon the metabolic disorder, it also depends upon the respiratory disorders also will alter the bicarbonate level. They said to assess the metabolic acid base disorder, we need a PCO2 independent parameters to assess the metabolic disturbances. Okay. This Dutch group will propose initially they said something is called a standard bicarbonate to assess the metabolic acid base disorder. Later there is some of the limitation with the standard bicarbonate, then they later introduced something called buffer base. Finally they produce it also has some limitations. Later they tell the base excess, something called standard base excess, it won't be affected by the PCO2 level. it give idea about, or it can quantify the metabolic acid base disorder. Okay. So, which is with the base excess approach, we call it as a Copenhagen approach. Okay. First, we will discuss about what is standard bicarbonate. Okay. So, standard bicarbonate. So, before going to the standard bicarbonate, we should know something. It's called calculated bicarbonate and measured bicarbonate. So, calculated bicarbonate means which is we won't directly measure, we calculate from the some other parameter. The measure means we directly measure a bicarbonate in the blood. So, something is called the measured bicarbonate is a total carbon dioxide. It is called measured bicarbonate. The calculated bicarbonate divided into two. One is the actual bicarbonate, second is the standard bicarbonate. So, before going to discuss about the bicarbonate level, what is total bicarbonate, measured bicarbonate, what is actual bicarbonate, what is standard bicarbonate, we should know about that how carbon dioxide is transported from the tissue to the lung. Then only we can understand the what is total bicarbonate, what is actual bicarbonate, what is standard bicarbonate. So, whenever that normal metabolism, I am not doing any work, my body will produce almost 200 ml of carbon dioxide per minute. What will happen to exercise? The carbon dioxide production may increase up to 5 times of my normal range. This carbon dioxide will go, it will transmitted through the blood to the lung by the almost, it is a 4 ways. Okay. One is that this carbon dioxide level in the tissue will increase. This carbon dioxide will goes to the RBCs. It bind with the hemoglobin. It produces a carbaminohemoglobin. Okay. This is the one method my carbon dioxide is transmitted from the tissues to the lung. The second is that some of the carbon dioxide will dissolve in the blood. Okay, it is a dissolve is a second method. This is a 1 and 2. Okay. The 3 is some of the carbon dioxides will bind with the plasma proteins. It produces a carbamino components. Okay, this is the third. The predominant one is that these carbon dioxide will react with the water. It produces a carbonic acid. This carbonic acid will dissociate. Will produce the bicarbonate and the H plus. So, if example this bicarbonate, this H plus will bind with the hemoglobin. Okay, leave it. So, this bicarbonate will be expelled, go to the plasma to maintain electron neutrality. One molecule of bicarbonate comes from the RBC to the plasma. One chloride molecules will go to the plasma to the RBCs. Okay, there is a 4 methods my carbon dioxide is transported from the tissues to that. One is the binding with the protein, second one is the binding with the hemoglobin, third one is the bicarbonate, fourth one is the dissolved in the plasma. The most predominant method is it is a bicarbonate. That is the reason whenever my PCO2 increase, my carbon dioxide levels are increased, my bicarbonate levels are increased. Other hand, in the lung, what will happen? It is completely reversed. Okay, if it is a lung, there is oxygen will come from the alveolus to the hemoglobin. Okay. This oxygenated hemoglobin will release the H plus ion. These H plus ions will again bind with the bicarbonate. It produces a carbonic acid, and the carbonic acid and the water. This carbonic acid goes to the lung. It is expelled by the ventilation. Will remove the carbon dioxide from the alveolus. Okay. So, there is a 4 ways my carbon dioxide is transported from the tissues to the lung. One is that transported as a bicarbonate. It is a predominant 95%. Second one is a 5% is a dissolved in the plasma. Third one is a less than 1% is transported through the plasma proteins carbamino, and less than 0.01% is transported as a carbonic acid. Okay, the predominantly it is 2. It is a bicarbonate and the dissolved in the blood plasma. Okay, so we will come to that. What is total bicarbonate? Which is our measured bicarbonate is called as a total bicarbonate. Some people will call it as a total CO2. Okay. So, usually we will check, we will send a blood samples to labs. They will measure a urea, creatinine, bicarbonate, chloride and sodium. Okay. This is actually what lab is measuring my total carbon dioxide level in the blood. This total carbon dioxide level is my total bicarbonate. Okay. All these parameters will include and give a value of bicarbonate. It is called total CO2. It is a measured value. It from the lab. Okay. But what is the problem here? It's a pure metabolic parameter. It's pure metabolic. It's only affected by the metabolic. No, I already told. Whenever the carbon dioxide level increases, my bicarbonate or carbamino component, dissolved carbon dioxide, everything will increase. So, it is a PCO2 dependent, not an independent marker of metabolic disturbances. Okay. The total bicarbonate is a measured bicarbonate. Okay. So, the venous blood used to have slightly higher PCO2 carbon dioxide in the blood. So, the total bicarbonate level slightly higher than the ABG value. Normally, we will check ABG and VBG, you always see total bicarbonate level used to be higher in the venous blood compared to the arterial blood. Okay. So, the total bicarbonate not an ideal marker to assess the metabolic disturbances, one, because it is affected by the respiratory disturbance, all one. So, to something is called actual bicarbonate, which you will usually measure through the ABG. Previous one, we send a samples to the lab, like urea, you will measure urea creatinine and bicarbonate. These things will be done in a lab, it's a measured value. Something is called actual bicarbonate, which is used by measured by the, it is not measured, it is calculated. It is by the ABG machine. It is not measured one, it is a calculator. You will see how it is ABG machine calculate the bicarbonate from pH and the PCO2. Okay, we all know that this is a Henderson-Besselbach equation. If the pH, bicarbonate and PCO2, if I know my PCO2 level and the pH, so I can calculate my bicarbonate. This is the formula. This is a log bicarbonate. It depends upon pH and the PCO2. Okay. It is also PCO2 dependent. If PCO2 increases, my bicarbonate also will increase, not a independent marker of metabolic disturbances. Lab is our measured value, but it is slightly overestimate because it included all carbon dioxide, the mode of transport, all molecules of carbon dioxide, so bicarbonate, carbon, everything is included. Okay. Actual bicarbonate is a calculated from the pH and PCO2. So, it is a PCO2 dependent. So, it is an not a ideal marker to assess the metabolic disturbances. So, to overcome that, the Dutch group, the Copenhagen group, something they suggested something called standard bicarbonate. What is standard bicarbonate? Standard bicarbonate means this whatever that my actual bicarbonate. So, example, my ABG machine showing my bicarbonate is 40, okay, which may be a metabolic alkalosis, it may be a chronic respiratory acidosis which increased my bicarbonate. There is two possibilities there. Okay. How do I know? It is because this bicarbonate level is high because of the CO2 retention, or it is because of the pure metabolic alkalosis. Okay. They said they all these actual bicarbonate they corrected with the PCO2 and the temperature, okay, to eliminate the respiratory component, which is proposed by Astra. Okay. What they said, whatever that example they measured a bicarb of 40 at the PCO2 of 60. They said at the PCO2 60, my patient's bicarbonate is 40, my PCO2 is 40, what will be my bicarbonate? Okay. For example, they corrected my, if example, this PCO2 level, my bicarbonate level is 50, what normally at the 40, my PCO2 of 40, my bicarbonate level. Okay. The standard bicarbonate is a plasma bicarbonate concentration after equilibrium at the PCO2 of 40. Okay. So, if equilibrium with the PCO2 of 40, the respiratory component is eliminated. The standard bicarbonate is predominant, it is only represent the metabolic acid base disturbances. So, it is very important. If the respiratory disturbances, my total bicarbonate will increase, altered, my actual bicarbonate altered, by the standard bicarbonate won't altered by my respiratory disorders. So, what are the, it looks good to assess the metabolic disturbances, but it is ideal one? No. Why is that? We all know that in the previous class in the acid base balance, we discussed about what is buffer system means. Any change in acid base system in our body, the buffer will prevent the extreme changes of my example. I added some amount of acid to the body. Immediately what my buffer will do, buffer system will come, it will neutralize that acids, so to prevent the pH change dramatically. It is called buffer effect. Okay. There is two types of buffers are there. One is a carbonic buffer system. Second is a non-carbonic buffer system. The carbonic buffer system is our bicarbonate. The non-carbonic buffer system, all our phosphate, protein, hemoglobin, all will contain the non-carbonic buffer system. whenever any change in the acid content in the body, both carbonic buffer system and non-carbonic buffer systems will come and neutralize the acids, okay, normally, okay. But when I am measuring a standard bicarbonate, the contribution of the non-carbonic bicarbonate weak acids are non-carbonic buffers are ignored, okay. If example, the buffer effect of weak non-carbonic acids are not included when I using the standard bicarbonate to assess the metabolic acid phase disturbances. One. Second thing, normally the non-carbonic weak acids are contribute the buffering of 14 to 16, okay, per liter. So, whenever adding a strong acid to the blood, my bicarbonate level will decreased because I added the H plus ions. This H plus ions, the bicarbonate will come, it bind with the H plus, it produce the water and the CO2. So, the bicarbonate level will decrease. My phosphate or proteins also will come, it bind with the H plus ions, will decrease the H plus ions. So, the phosphate level also will decrease. So, and I add strong acids added to the blood, both bicarbonate and the is A minus is a non-carbonic acid, both will be reduced. If example, I added 10 millimole of strong acid to the blood. My baseline bicarbonate level was 24. What will happen? Each mole of strong acid will decrease the 1 molecule of bicarbonate. What would be the bicarbonate? Ideally should be 14. So, but what is actually my bicarbonate is 16. Why? It is higher than the normal. For that reason is non-carbonic buffer system also will neutralize the acid. If example, I added the 10 moles of acid, my 8 molecules are neutralized by bicarbonate, the 2 molecules are neutralized by non-carbonic acid buffer system. Okay. So, if it is only buffer system, what will happen? My bicarbonate level will be 14. Because of non-carbonic, my bicarbonate buffer system is 16. So, my standard bicarbonate values usually slightly underestimate the metabolic acid base disorder. It is one of the limitation of standard bicarbonate. To overcome that, the Dutch group proposed one more parameter can measure the metabolic acid base disorder, which is something is called buffer base. What is buffer base? Nothing. The buffer system in the body, I already told there is a 2 types of buffer system in the body. One is that carbonic buffer system, second is the non-carbonic buffer system. The carbonic buffer system is our bicarbonate. Okay. The non-carbonic buffer system is our plasma protein, hemoglobin and the phosphate. So, the total concentration of all this buffer is called the buffer base. Okay. The bicarbonate level, example, you see here, this is my buffer base. So, bicarbonate level plus A minus, which is the other non-carbonate buffer system, our plasma protein, hemoglobin and the phosphate. So, the A minus and the bicarbonate, it is called the buffer base. So, if example, if I add some acid to the patient's body, okay, for example, I added 10 moles of acid, okay, all these ads are neutralized by one by the bicarbonate or it may be A minus, that is a non-carbonic buffer system. So, the total buffer base will decrease, 10 mole of acid is added, so 10 mole of my total buffer will decrease. It may be a bicarbonate, it may be this acid, okay. So, based on the quantifying the buffer base will give idea about how much acid is added to the patient's body, okay. So, the buffer base is a sum of weak acids of all anions in the buffer anions in the plasma. It's normally it's a 45 to 50 milliequivalent per liter. It is nearly all these buffer capacities, mostly it's contributed by the hemoglobin and the bicarbonate. So, the normal you can calculate the buffer base by this formula, it's 41 plus 7 plus 0.02 into my hemoglobin level. So, it is the latter the buffer base concept is reintroduced by the as a strong ion difference by the Stewart. And we will discuss this separately in the Stewart approach of acid base disorder. So, there is a formula that to calculate the buffer base, that is we already discussed, is the normal buffer base equal to 41 plus 7 into 0.42 into our hemoglobin level. We can calculate the buffer base. We already discussed buffer base is the weak acids of anions in the buffer anions in the blood. It includes the hemoglobin, plasma proteins, phosphates and the bicarbonate. Hemoglobin, plasma proteins and phosphates are called as a non-carbonic acid buffer system. Bicarbonate is a carbonic acid buffer system. The combination of both carbonate and bicarbonate buffer system, bicarbonate and non-carbonic acid, that is a non-bicarbonate buffer system, or both the concentration of all these two is called as a buffer base. Okay. How can the buffer base is respiratory? We already told that the bicarbonate is respiratory dependent, but standard bicarbonate is non-respiratory dependent, but standard bicarbonate is not included the non-carbonic acid buffer system. So, the buffer base has two advantages. It is respiratory independent. Second is it is included the non-carbonic acid buffer system also. So, how? If example, if I added my respiratory acidosis, okay, the PCO2 is increases. The PCO2 will bind with the water, it produces H plus ion and the bicarbonate. Both the H plus ion and bicarbonate ions are increased. So, the bicarbonate level is not a good indicator to assess the metabolic disorder because it is a respiratory dependent. Okay. What happened to the buffer? Okay. So, what happened here? That A minus I already told that is a non-carbonic buffer system. It is a plasma protein, hemoglobin and the phosphate. So, one molecule decrease in the A minus. Okay, this is the bicarbonate buffer system won't work in the respiratory acidosis because it is a component. For example, PCO2 is increases, my H plus and bicarbonate ions are increased. The bicarbonate cannot neutralize this H plus ion. So, it is all the, if respiratory acidosis is buffered by the non-carbonic acid buffer system. So, if example, the respiratory acidosis increase acid is neutralized only by this plasma protein, hemoglobin and phosphates, predominantly by mainly by the hemoglobin. If every molecule increase in the hydrogen ion and the bicarbonate, PCO2 increase, it increase the one molecule of H plus and one molecule of bicarbonate. What my carbonic, non-carbonic buffer system, it go and neutralize this. So, the one molecule decrease in the A minus, which means that the non-carbonic buffer acids will decrease, each molecule increase of H plus ion and each molecule increase. So, the one molecule decrease in the A minus with also one molecule increase in the bicarbonate. Okay, the buffer base buffer is equal to plus H plus and bicarbonate plus the A minus. In respiratory acidosis, what will happen? The A minus one molecule will decrease, the bicarbonate one molecule will increase. What will happen? The buffer base will be constant. Okay. So, it is a respiratory independent. If the respiratory acidosis, the buffer base concentration won't change. So, bicarbonate level may increase, but the other non-carbonic buffer base anions will decrease. So, the buffer base will be constant. So, it is a respiratory independent. Second, if you see here, it is a metabolic. If I add the hydrochloric acid, okay, hydrochloric acid, what will you do? It produces H plus ions and the chloride. The increased H plus ions will be neutralized by bicarbonate or it may be A minus. So, every increase of the H plus ion will decrease the one molecule of, for example, there is a 10 molecules of H plus ions or hydrochloric acid is added, it produces a 10 molecule of H plus. It may be 5 molecules will be neutralized by non-carbonic buffer, 5 molecules may be neutralized by bicarbonate. Okay. So, what will happen? The 5 molecules will decrease in the A minus and 5 molecules will decrease in the bicarbonate. Okay. So, what will happen? The buffer base equal to A minus, there is a non-carbonic buffer and the bicarbonate. Okay. This is also decreased, this is also decreased. Okay. What will happen? In the metabolic acid base disorder, whenever adding a fixed acid to the blood, it may be a renal failure, it may be a DKA, whatever, it may be a lactic acidosis, what will happen? My buffer base will decrease. So, the buffer base is, it is a respiratory independent, but it is a metabolic dependent. So, it is a buffer base is it also included the carbonic acid buffer system also. Compared to the standard bicarbonate, the buffer base is it's a good method. The estimation of buffer base is a good method to assess the metabolic acid base disturbances. Okay. So, this method also has some limitations because it gives idea about the metabolic disturbances, but we cannot quantify. For example, the base excess minus 5 means there is a 5 moles of acid is extra in the blood. In the buffer base, cannot quantify the buffer metabolic acid base disturbances as like base excess. To overcome that, the Copenhagen group, the Sigurds, the Anderson and all introduced something called base excess. Okay, it is nothing. Base excess means It is a difference between that actual buffer base in the body compared to the normal. For example, the normal buffer base is 40. My patient's buffer base is 30. What will the base excess is a minus 10. So, buffer base excess is the difference between the actual buffer base in the body and normal buffer base. Okay. It's a difference between these two called base excess. There is some formulas are there. You can calculate the base excess whether is the actual patient's bicarbonate. This is a normal bicarbonate. Either it's already told there is a two buffer systems are the beta is the non-bicarbonate buffer system. Its normal value is around constant is 16.2. Is the patient's pH is the normal pH. From that we can calculate the base excess. Okay. So, normal range of base excess is -2 to +2 millimole per liter is considered normal. Okay. Here I already told what is the advantage of that. For example, it is a 10. I already told the base deficit is -10. Base excess is -10. What does it mean? The 10 millimoles of acid is extra in the body. If, for example, I want to correct that, I have to give a 10 millimole of extra bicarbonate to neutralize that. It give idea about how much bicarbonate I had to give the patient's body to neutralize the acid. This is one advantage of base excess method compared to the base buffer.